All right, well, good afternoon, everybody. Hope you're having a good day so far. I think I saw most of you yesterday. For those that I didn't meet yesterday, my name is Dr. Broderick, emergency medicine for 35, nearly 40 years. A couple of follow-ups from yesterday. If I'm talking too fast or something that I say does not seem clear, just wave me down and stop me, and we'll go over that again. That's number one. Number two, I realize that some of the material we're talking about may be a little confusing because you haven't gotten into some of this yet in your training. So I want you to just sit back and look at the big picture of what we're talking about. I don't expect you to come out of these things and be able to sit for a board examination on some of these questions, but I want you to just kind of start to incorporate this into the foundation of your education. So today we're going to talk about non-traumatic abdominal pain, and we'll go over some patient scenarios that are very common in emergency medicine or family practice or in surgical residencies, because these things occur commonly. So regardless of what field you end up in, you are somehow going to have a touch on this. You will certainly have a touch on this in your third year of clinical training because you rotate through all of the various specialties. So much of what we're going to talk about today, you're going to have exposure to. And again, if something I say is not clear or you have a question about something, just please flag me down and we'll stop and go over it. Okay? Okay, so today we're going to go over atraumatic abdominal pain. Obviously, with trauma and abdominal pain, there's another whole host of things that we could be talking about, but we'll focus on patients that present to you in your office or in your clinical setting with abdominal pain. Because the abdomen is essentially a black box, meaning it's a mystery. You need to, as a clinician, be able to take a good history, a good physical examination, and then let that guide your decision-making. Many times you can see a patient with abdominal pain, and if you spend time on a good history and physical examination, you can come up with a reliable diagnosis, and you don't necessarily need to do any further testing. You can treat the patient and be on to the next patient. Other cases, either because of the level of severity or things that are in the differential diagnosis, you need to be more careful and you need to order some additional testing and evaluation to make sure that you're not missing something that could be a catastrophic problem. Okay, so let's go ahead and get into case number one. Okay, I'm gonna go ahead and read this because I think it's hard to read a little bit up there for you. So case number one, a 42-year-old female with a history of cholelithiasis. Cholelithiasis is gallstones. History of cholelithiasis, presents to the ED with abdominal pain. On physical examination, the patient appears jaundiced. Typically, you need to have a bilirubin of probably 3 or 4 before you're going to start seeing visible jaundice. So already you can say, normal bilirubin might be 1.5 on your laboratory testing. To be jaundiced, you need to have a bilirubin of about 4. Basically saying this is 3 times the upper limits of normal. So patient is jaundiced, has right upper quadrant abdominal tenderness or palpation. Patient is febrile to 38.5 or 101.3. Blood pressure 139/75, which is acceptable. Heart rate is 93. Respirations are 17. Oxygen saturation 99%. Remember we said O2 saturation 92 to 100 is essentially within normal range. 90 to 100 is essentially normal range. Labs reveal a white blood cell count of 19.8. Depending on age, normal white count is between 4 and 10,000. This is 19,000, so significantly elevated. Alkaline phosphatase is 150, mildly elevated. Alanine and aminotransferase, 120, very mild elevation. Aspartate aminotransferase, 170, and direct billing, 1.9. That's a pretty good clinician if they diagnose jaundice with a billing of 1.9. Because again, clinically, usually it takes about a billing of 4 before you start to see clinical jaundice. Okay, so things in this history that should concern you. Number one, right upper quadrant pain and tenderness, highly suggestive of biliary tract disease. Either cholangitis, ascending cholangitis, acute hepatitis, pancreatitis, all can give you right upper quadrant pain. So right away you should be thinking, right upper quadrant, got to rule out something in the biliary tract. The fact that the patient has a temperature of 38.5 is somewhat bothersome, because now you have a patient with a known history of cholelithiasis, has gallstones, has pain and tenderness in the right upper quadrant, and now they're presenting with a fever. So you're starting to get worried about these patients, because these patients can go into septic shock very, very quickly. So this is one that you need to be much more concerned about how you evaluate this patient. A white count of 19.8 thousand, that's essentially twice normal. When you get a CBC, complete blood count, it's going to give you a white count, it's going to give you a lot of other parameters. It's also going to give you a differential of what type of white cells are elevated. In this case, with a white count of 19.8, worry about a temperature and maybe an infection in the gallbladder, i.e. cholangitis. You're probably going to see something, a lot of immature leukocytes. You're going to see a lot of, the bone marrow is pushing out immature leukocytes to fight infection. Okay, they're called bands, B-A-N-D-S, bands. So in this case, normally you might see 0 to 5% bands on a white count. In this case, this person probably has bandemia, which means elevated immature white cells. Your body is responding to this stress, trying to send out white cells to fight the infection. So right now we have an elevated white count, we have a fever, and we have right upper quadrant tenderness. This patient I'm worried about. Fortunately, because the blood pressure is stable, 139/75, she's not tachycardic with a heart rate of, 93. She's hemodynamically stable. She's holding her own, but a few things about that. At the extremes of age, little tiny children or elderly people, they do not have really good reserves or good capacity. So when they get sick, they sometimes get sick very, very quickly. With normal, healthy, middle-aged adults or everybody in this room, you have capacity to compensate for illness. So it takes a while for your vital signs to change significantly. But if this patient has a bad gallbladder infection, there's a very good chance that if untreated for 24 or 48 hours, they're going to decompensate quickly and they can develop bacteremia or bacteria in the blood, and they can develop sepsis, and then there's a whole cascade that goes from there. So let's see what we got going on here. So those are some of the key elements in this particular case. So in emergency medicine in the last 10, 12 years, we've gotten much more involved in doing point of care bedside ultrasound. The technology is wonderful. You will have exposure to this either in your training here or in your clinical training in your 3rd and 4th year. And it's very easy to put an ultrasound probe over the right upper quadrant just to see if you can see signs of gallbladder swelling, edema around the gallbladder. Is there a stone that's obstructing the common bile duct? Fairly easy to do, and it'll help guide your plan as to what the next things to do are. So in this case, patient has an ultrasound that shows a common bile duct of 8 millimeters, upper limits of normal. Anything over 10 millimeters is elevated. So this is getting close to upper limits of normal. So a patient is started on intravenous fluids and broad spectrum antibiotic. For somebody that you're worried about septic shock or infection, what type of fluid might you think you would give them through intravenous? I'll give you options. Would you give them D5W, which is sugar water? Would you give them half normal saline, or would you give them normal saline? Normal saline being 0.9% normal saline. Yeah, whenever you want to really fluid resuscitate somebody, don't give them just pure water. It doesn't stay in the intravascular space. It leaks out into the tissues. So if you just gave them dextrose and water, yeah, you're giving them sugar, that's not going to help stay in the intravascular space, and it's not going to significantly improve their blood pressure. So these are the patients that you either want to give normal saline or lactated ringers, something that is isotonic. Isotonic means essentially the same tonicity as blood. It's going to stay in the intravascular space better. So the patient's going to get, you suspect a bad infection, you give them fluids. How much fluids should you resuscitate someone with? Now, so I'll give you options. 500, so let's say this is a 70 kilogram person. 500 cc's of normal saline, 1,000 cc's of normal saline, or 2 liters of normal saline. Blood pressure right now is good, but you suspect that they're getting their early sepsis or that they're a little bit dehydrated. In emergency medicine, we hang up one bag, and the nurse says, how fast? I say, wide open. She says, doctor, that bag is in. What do you want me to do? Hang up another bag. So for a full-grown adult with normal kidney function, you can give them 2 liters of fluid over 1 hour and that's how you fluid resuscitate somebody. If you have trauma cases and other cases, we actually put those bags on a pressure bag to kind of infuse that fluid in very, very quickly. So in this case, patient's gotten fluids. We give a broad spectrum antibiotic because the right upper quadrant's kind of a dirty area. You can get E. coli, which is probably the most common, and you can also get a lot of anaerobic type of infections from right upper quadrant infections. So we give a broad spectrum antibiotic, some kind of broad spectrum cephalosporin or broad spectrum penicillin or combinations so that you get gram-negative coverage and anaerobic coverage. As far as these tests are concerned, we'll go through kind of what these are and what they will help determine. So the first one, A, is endoscopic retrograde cholangiopancreatography. It's called, for short, ERCP. Basically, what they do with that is they cannulate the biliary tract, inject the dye endoscopically, and so that it will light up the biliary tract. You'll be able to see the pancreas, you'll be able to see the common bile duct, and that'll help give you an idea whether there's an obstruction. Because if a stone is obstructing the common bile duct, that can be a surgical emergency or at least a endoscopic emergency where you need to do something. B is called a HIDA scan. This is a nuclear medicine scan. We don't use that in the acute setting. That's something that you do for a patient that doesn't have gallstones that maybe you're concerned about a chronic cholangitis. MRI is great, but has anybody ever had an MRI? Yeah, I mean, you've got to put somebody into a pretty narrow tube. They can't have any resuscitation instrumentation out there that's not MRI safe. If your patient's at all unstable, you don't want to send an unstable person or somebody that's very sick into the MRI tube until you've really been able to resuscitate them. So MRI can be great, particularly in pregnant patients if you don't want to give them radiation to the abdominal and pelvic area. So MRIs are great, but they take longer and it's very difficult to effectively monitor a patient while they're in the MRI machine. So those might be some of the diagnostic tests that you would do to kind of ascertain what's going on with this patient. So we'll just kind of go over this. So in this particular patient, you would want to call your gastroenterologist and you would arrange for an ERCP. And this is going to be the best diagnostic test for you to be able to evaluate what's going on with this patient. It will help diagnose cholangitis. This patient may have what's called ascending cholangitis. We'll talk a little bit about what that is. ERCP is the diagnostic tool of choice for that. Cholangitis can be life-threatening because you can progress to a septic shock very, very quickly with this. You can also detect that sometimes, usually these are a more indolent or a slower course, but you can detect patients who have cancer in the biliary tract. Not as sudden as somebody who passes a stone and gets an obstruction, but biliary tract cancer can sometimes present with acute infection in the right upper quadrant. This Charcot Triad, right upper quadrant pain, fever, and jaundice, which this patient have, Charcot Triad, about 50% of the patients who present with cholangitis will have that. If the patients develop hypotension and an altered mental status, that's called Reynolds Pentad, and that has a very high mortality. That means that not only do they have cholangitis, but now they're developing an infection and sepsis associated with that. Elevated liver function tests can be along with that. We said aggressive intravenous fluids, normal saline or lactated ringer, broad spectrum antibiotics. Dilatation greater than 6 millimeters in the presence of gallstones is choledocholithiasis. Choledocholithiasis. That means you have an obstructing stone in the biliary tract. The ERCP, when they do that, the endoscopic retrograde cholangiopancreatography, they can also actually visualize, and they make a little cut at the bottom of the biliary tract to help dilate the sphincter of Oddi, and that will help them pass that stone. So not only can the ERCP be diagnostic, but it can be therapeutic as well. Anytime you have a closed system, whether it's an abscess or a biliary tract that's obstructed or a bowel that's obstructed, and you have an infection associated with that, you can give all of the antibiotics that you want in the world, and you're not going to effectively treat that. You need to relieve that obstruction. So if you have an abscess, you need to drain it. If you have an obstruction, you need to remove the obstruction. If you have an obstructed bowel, you need to relieve the obstruction. Because if you have infection and obstruction and a closed compartment, the antibiotics are not effectively going to get into that area to treat infection. So this is a case where you would want to get early surgical intervention for possible cholecystectomy, which is essentially removal of the gallbladder. Most of the time, the surgeons are going to want the patient adequately fluid resuscitated, broad spectrum antibiotic, systemically optimized, so that when they go to the operating room, that they have the best chance of a successful surgery. So a little schematic of the biliary tract. Typically, most of your obstruction is not going to be in the cystic duct, it's going to be in the common bile duct. And as we talked about, here's where they may make an incision to help relieve that. Because oftentimes the common bile duct the stone will get further down in the common bile duct and then kind of get hung up at the sphincter. We talked about the type of broad spectrum antibiotics, piperacillin, tazobactam. It's a kind of a higher generation penicillin that has a lot of gram-negative and anaerobic coverage. You want to drain the area. Remember, this will be something that you'll hear about. Charcot Triad, fever, abdominal pain, jaundice, okay? Patients who present right away, you should be thinking about this is ascending cholangitis. Typically, these patients are going to come in with rigors, shaking chills. Here's one take home for you guys for today. Patients who present with fever and a history of rigors, shaking chills, they are bacteremic until proven otherwise. You can certainly get shaking chills with the flu, a viral illness, but in patients that are at risk for bacterial infection and you don't have an alternative diagnosis, patients with shaking chills are bacteremic until proven otherwise. You need to do blood cultures on those patients and initiate antibiotics unless you have another source, influenza, COVID, what have you. You add confusion and hypotension, essentially altered mental status confusion, hypotension, signs of systemic cardiovascular collapse. Now you have a very, very sick patient that can deteriorate very quickly. Patients who present with Reynolds, Pentad are typically going to end up in an intensive care unit post-operatively. We talked about the HIDA scan. That's what you may diagnose. So let's say you do an ultrasound and you don't see any stones and you're still concerned about biliary tract disease. 1 second. You do a HIDA scan to determine if the patient has chronic cholecystitis, and usually about 5 to 10% of acute cholecystitis may be what we call acalculous cholecystitis. There's no gallstones, but they still have an infection in the gallbladder, and it's usually in patients who have been in the ICU for a while or people that are otherwise very, very sick, and a HIDA scan will be used to determine that.
The question I had was discussed last nurse already. So in this particular case, we have a patient with Charcot raised the Reynolds is positive, and basically you put them. My question is like, if you have proof that there's a stone in the bowel duct, right? Would you first put them through an ERCP and then consult surgery for cholecystectomy, or could you do cholecystectomy right away if you're approved because you're going to do it anyway without stating twice?
You pick up the phone, 2 phones. Get me GI, get me general surgery. You like to get them to talk to see how they want to manage it, but typically you want to do ERCP first. Number 1, you relieve the obstruction. Remember, I said you want to optimize their clinical condition before they go to the operating room. No surgeon wants somebody to die on the operating room table. It's bad for business. So they want those patients optimized as best you can. So if you can relieve the obstruction, cover them with broad spectrum antibiotics, fluid resuscitate them, optimize them physiologically, the surgeon will much more likely to have a successful operation. You take somebody to the operating room who's being hemodynamically unstable or they're declining, that's a high-risk surgical procedure. Remember, when you give somebody general anesthesia, you are wreaking havoc on their physiologic response. And these people, usually their adrenaline, their sympathetic system is just charged up. That's why they're able to maintain their blood pressure. That's why they're able to maintain, their oxygenation. Once you put them under anesthesia, although it's a controlled situation, the body's response to all of these things, it just shuts down. So patients, when you induce them for intubation or you start the procedure, they can crash very, very quickly. So again, usually when you know somebody's pretty sick and you have a reliable ultrasound that's showing it, the clinical decision-making seems pretty evident, I'm usually talking to both of them. I can usually get the gastroenterologist to do our ERCP. The surgeon will see them and say, get them optimized, we'll book them for the operating room in 12 or 18 hours. So a combination. As I said, MRIs are great, but they're not therapeutic, and they take a while to do, and they can give you a lot of information, but in an acute setting where somebody's really sick, you don't want to put somebody in the MRI machine. And as we talked about, most common pathogen associated with cholangitis, E. coli, maybe up to 50%, Klebsiella, another quarter of them, and Enterobacter, another 5 to 10%, and then a whole cadre of anaerobic infections. There's 2 ways to look at this. Anything below the diaphragm, the diaphragm, infections below the diaphragm, these are likely organisms. Infections above the diaphragm, different set of organisms. Staph, strep, maybe Haemophilus, Klebsiella. E. coli pneumonia is not particularly common. E. coli infections below the diaphragm are common. So before we get into this case, just in summary, right upper quadrant pain, fever and jaundice, that's acute cholecystitis, cholangitis, till proven otherwise. You layer on mental status changes, signs of hypotension, that's really an emergency, you need to be very aggressive. If you're ever going to fluid resuscitate somebody, don't be wishy-washy, don't be middle of the road. They need fluid, give them fluid. Exceptions to that, patients who have congestive heart failure, very brittle, elderly patients, maybe on a lot of diuretics, a lot of cardiac medications. You need to be a little bit careful about fluid resuscitation. Maybe you give them smaller amounts and then reevaluate, smaller amounts and then reevaluate. So maybe 500 cc's at a time versus anybody in this room, if you came in with this, you'd be getting 2 liters of fluid right away. God bless. Okay, so gallbladder is a common presentation for right upper quadrant. So here's case number 2. We have a 45-year-old man presents to the ED with worsening abdominal pain. Pain is persistent pressure with burning in the epigastric area. That's a little bit of a clue, burning in the epigastric area. Medical history of heavy alcohol use and osteoarthritis. He's currently taking ibuprofen for pain in his left knee. Lab values are essentially normal. Physical exams notable for epigastric discomfort with palpation. What things in the history have you concerned? So epigastric burning pain, right? Epigastric burning. So you're thinking stomach, gastritis, peptic ulcer disease, maybe pancreatitis. He drinks alcohol, pancreatitis is a possibility. He takes non-steroidal anti-inflammatories, can give at risk for gastritis or peptic ulcer disease. There's only a couple things that are absorbed directly into the stomach. Alcohol is one of them. And non-steroidals work by breaking down the mucosal barrier in the stomach. So both of those together increase your risk of acute gastritis, hemorrhagic gastritis, esophagitis, peptic ulcer disease. So all of those can give you epigastric burning pain. So it's important, just a sidebar thing. A lot of things in medicine are related to medications that people are on. Never fail to get a good medication history from your patients, because oftentimes patients are on medications either prescribed or not prescribed, or somebody gave me this, they said it would help. A lot of times the medications we take can cause side effects. So in this case, combination of alcohol and ibuprofen set this patient up for some type of damage to the gastric lining. So does this sound like that last case of cholangitis that we had? Absence of a fever, not jaundice, more epigastric as compared to right upper quadrant. Cholangitis doesn't seem likely. Gastritis certainly seems like a possibility. And there's regular old gastritis, which is just inflammation of the stomach lining, which can be very painful. Then there's hemorrhagic gastritis, which is what you'll have bleeding. And obviously peptic ulcer disease is the kind of the sequelae of untreated gastritis. Gastroenteritis, what's absent in this patient that they don't have gastroenteritis most likely? Yeah, nausea, vomiting, diarrhea. I'm sure all of you through the course of your life have had episodes of gastroenteritis, and typically nausea, vomiting, diarrhea are going to be hallmark symptoms with abdominal pain. Pancreatitis. Typical signs and symptoms of pancreatitis include stabbing epigastric pain through to the back. Epigastric pain through to the back. Usually there's a history, probably more than 75% of patients with acute pancreatitis, it's due to binge drinking or alcohol, excessive alcohol use. Chronic alcohol can give you a chronic pancreatitis as well, but typically alcohol is going to be the causative agent for pancreatitis. For patients that have a obstructing biliary stone low down, you can get an obstruction of the pancreatic duct as well, and you can get sequelae from that. Don't underestimate how sick patients with pancreatitis can get. They can get sick quickly. Pancreatitis is essentially like a burn, an intra-abdominal burn. Those patients can be third-spacing fluid tremendously and require lots and lots of fluid resuscitation. I used to have a friend who was, he was a general surgeon, he specialized in hepatobiliary surgery, and he became chair of the Department of Surgery. Anybody that came in that was at all sick with pancreatitis, he wanted them in the ICU for the first 20 hours for aggressive fluid management and aggressive of treatment, because those patients can get sick very, very quickly. What's the blood test that we use for pancreatitis?
Serum amylase and serum lipase.
There's amylase and lipase. Typically, lipase is going to be a better, more sensitive tool over amylase. So part of the panel of testing you might see with somebody who's having an abdominal pain evaluation is going to include lipase. It was kind of my knee-jerk test that I would order when somebody was presenting with epigastric abdominal pain. I would always include a lipase in there, even without the history of alcohol use, because there's other non-alcohol related causes of pancreatitis. So gastritis. In this patient, that's the most likely diagnosis. Burning abdominal pain, alcohol, ibuprofen, secondary to mucosal injury of the stomach, irritants like alcohol, NSAIDs, aspirin, prednisone. The thing about steroids too, by the way, you have patients who are on steroids either chronically or a 2 or 3 week course of steroids for some type of steroids mask your abdominal pain. I've seen patients that have had a perforated viscous, perforated peptic ulcer disease on steroids, and they have a very benign abdominal exam. The steroids, they're strong anti-inflammatories. They suppress the inflammatory response. They also blunt the pain receptors. So a lot of patients on steroids are going to have a very altered exam. So if a patient comes in and they're taking prednisone or whatever, just think in your mind, okay, their examination might not be particularly reliable, and I may just have to have other indexes of suspicion. H. pylori, very, very common, very, very common cause. My wife and I had done some mission work in Haiti a number of years ago, and pretty much everybody that came in with abdominal pain, we were testing for H. pylori because it was very, very common there. Probably upwards 25 to 50% of the patients that had gastritis, it was secondary to H. pylori. There's a breath test that you can do for that, or you can do a stool sample for that. So typically the pain of gastritis is going to be gnawing, described as a burning, pressure, discomfort. May improve or worsen with eating. That helps differentiate duodenal ulcer disease versus peptic ulcer disease. So just need to get that into your history when you're taking it. Patients who continue to drink, ulcers and gastritis don't heal. Patients who continue to smoke or smoke tobacco, it's bad. The nicotine prevents ulcers and gastritis from healing. So if you have a patient that presents with gastritis, they say, I'm not going to drink anymore, but you see them with a pack of cigarettes in their pocket, tell them you got to cut down on your nicotine too, because that also increases the acid in your stomach. Tylenol, no problem with that. Proton pump inhibitors will reduce acid secretion. So somebody who's at risk for acute gastritis, those are patients that they say, what can I take for pain, doc? Let's say somebody's a boozer and they say, I'm not going to stop drinking, but I need something for pain. Stay away from the NSAIDs. Tell them to take acetaminophen. Essentially, they're identical when it comes to pain relief. If you suspect an H. pylori, those patients need antibiotics, and usually it's a combination of a couple of antibiotics for that. A schematic of gastritis showing inflammation, hyperemia, maybe some punctate hemorrhages there, diagnosed either clinically or by endoscopy. Complications are obviously development of bleeding. Just a word about this. Anybody that comes in with belly pain, you think of peptic ulcer disease, hemorrhagic gastritis, you need to take a history. Have you vomited any blood? Hemoptysis. Have you vomited blood? Hematemesis. Hemoptysis is coughing blood. Hematemesis. Have you vomited blood? Somebody says, yeah, I vomited some bright red blood. Well, that means maybe they have active bleeding going on. Somebody says, I vomited coffee ground or black coffee ground material. That's digested blood. So it's essentially somebody bled, it sat in the stomach, the acid worked on it, and then they threw it up, and it turns out like black coffee grounds. Doesn't smell particularly good either. These are the patients you take a history of. You vomited at all, you had any blood in the vomitus, you ask them about their stool. You had any blood in the stool? They said, no, but my stool was real dark. That's melanoma. Black stool typically is melanoma. Another type of stool is called hematochezia. That's like a purplish blood. That means that it's a brisk bleed, but maybe a little bit higher up. And then obviously bright red blood from the rectum is another form of bleeding. And that usually means either a very acute bleed or bleed in the lower intestinal tract, rectal bleeding, bleeding from sigmoid or something like that. You get bright red blood. All these patients need to have a rectal examination to make sure that their stool does not contain blood. We do a test called a Guaiac test. It's a little tiny card. Take a small stool sample. You put a couple of drops of a reagent on there. If it turns a blue color, then you know that there's blood in the stool. So that warrants you to further investigation. And believe me, people with gastritis, hemorrhagic gastritis, they can bleed a lot. They can actually bleed a lot. They can drop 1 or 2 units of blood from hemorrhagic gastritis. We talked about cholangitis, so that's not in this particular case. The gastroenteritis, you're going to have nausea, vomiting, diarrhea. Pancreatitis, usually epigastric, you'll have an elevated lipase, secondary alcohol, or like I said, a sequelae of gallbladder disease or an obstructing gallstone. So you treat the underlying cause, you put them on either proton pump inhibitors or H2 blockers, tell them to stop drinking, stop taking the non-steroidals. Patients with chronic H. pylori or chronic reflux are at risk for esophageal cancer, gastric cancer. So you don't want to miss H. pylori. So if somebody has recurrent gastritis or peptic ulcer disease, you should be testing them for H. pylori. Patients who have reflux, GERD, gastroesophageal reflux disorder, that's kind of chronic in nature. They need to have endoscopic evaluation and biopsies to rule out Barrett's esophagus, which can progress to distal esophageal cancer. So take home on that, epigastric pain, think in terms of stomach, so gastritis, peptic ulcer disease, duodenal ulcer disease. Think in terms of pancreatitis as a potential cause. Take a good history, look at risk factors, look at medications, make sure you ask them about alcohol. You know, somebody says, I say, do you drink? And they say, well, a little. Well, how much is a little? Well, I drink, a 6-pack of beer a night. And that, to them, that may not be a lot, but that's probably too much to be drinking. There's a saying that you don't drink a lot unless you're going to your doctor, so it really depends on which doctor you get as far as whether it's determined that you drink a lot. But alcohol certainly is a big risk factor. Let's see. So here's another case, very similar history, burning epigastric pain, relieved by ingestion of milk, food, and antacids. Okay, so antacids are healthy. Gastritis, could be an ulcer. Wakes him up at night. What's up with that? The stomach is empty. There's nothing for the acid to be working on. So it's irritating something in the stomach. Vital signs are normal. Physical exam significant for mild epigastric tenderness. Again, this patient should be having a rectal examination. Patients are coming in to see you. They deserve to have every orifice checked. So if anybody with abdominal pain, and this will happen to you guys as third years or as junior residents or what have you, you're evaluating for somebody with abdominal pain, you fail to do a complete examination, that includes a rectal examination, you're going to get your ass chewed out by your senior resident or your attending because that's part of the physical examination. And once you've done 1,000, it doesn't bother you anymore. So in this particular case, is there anything that would make you want to get a more urgent endoscopy? Yeah, the weight loss. That's kind of, that's kind of scary, right? Weight loss. Daily ibuprofen, that can be from gastritis. Several week history of this, a little bit more of an indolent course. waking you up at night. A positive urea breath test, that usually is the, positive urea is usually an indicator of H. pylori, unexplained weight loss. If this patient had unexplained weight loss, that would definitely be something that you would want to get an urgent endoscopic procedure for. Typically with this, you can get weight loss with peptic ulcer disease because patients typically don't eat as much. It's going to improve with food or antacids. When your stomach is empty, it's usually going to make it worse. That's why sometimes patients with peptic ulcer disease will eat small, frequent meals. Benign exam other than mild epigastric tenderness. H. pylori, very common. Once you have a peptic ulcer disease, duodenal ulcer, they do biopsies and they test for H. pylori because it's very, very common. North of 75% of patients with peptic ulcer disease. Endoscopy is really the gold standard. I think we have a picture of peptic ulcer disease here. The classic history is pretty much with this, and you're going to treat them with at least 6 weeks of proton pump inhibitors. You're going to tell them to stop boozing, stop the non-steroidals, and if they smoke, stop smoking. If you're worried about recurrence and GI malignancy, certainly unexplained weight loss is something that you need to evaluate. Now this says include age greater than 55. I'd even lower that. There's been a trend now, not only with colon cancer, but with gastric carcinoma, younger and younger individuals, probably from a lot of processed foods that we eat. But we've been seeing a trend over the last 25, 30 years where the recommendations for colonoscopy and evaluation are getting younger and younger and younger. So these are things that you need to keep in mind when you're taking a good history. Example of peptic ulcer, I don't know if this will show here. So this is probably blood in there. Here's the peptic ulcer right here. This right here, it looks like there's a little blood clot that is it's sitting there. This whole area looks very, very inflamed. Probably some old blood in the stomach there. This is the person who's going to present with melena because the bleeding is from the stomach. It's going to pass through the digestive tract, and by the time it goes into the lower colon, it's going to be black. These are the patients going to present with black, tarry stools. What's a medication that we sometimes see people take that's going to, well, there's two that come to mind, that will turn your stool dark or black. Patients are anemic, so sometimes they go on this medicine. Iron can turn your stools black. Pepto-Bismol, bismuth, can turn your, sometimes when you go to examine people, you say, open your mouth, stick out your tongue, and their tongue will be black. You say, you can take any medicine, they pull out their body, taking these chewable Pepto-Bismol will turn your tongue a dark color, and will turn your stool dark. It will not change your Guaiac test. It won't show up as blood in the stool, but it will turn your stool to a dark color. So iron and Pepto-Bismol or bismuth. Belching, regurg, more typical of GERD, gastroesophageal reflux, and that positive urea breath test is typical for H. pylori. We're going to jump past this because there's 1 or 2 cases I want to get to here. Okay, 32-year-old gentleman presents to the ED with abdominal pain, diarrhea, weight loss over the last 3 months, a much more indolent course, intermittent low-grade fevers, fatigue, diffuse abdominal tenderness with mild distension. Laboratories reveal elevated inflammatory markers and anemia, so he's probably got elevated citrate, elevated CPA. Abdominal imaging demonstrates segmental bowel wall thickening, particularly around the terminal ileum. Sometimes call that terminal ileitis. What do we think this patient has? 3 months, relatively young guy, abdominal pain, weight loss, diarrhea. What are the 2 biggies that we see in the intestinal tract? autoimmune diseases, Crohn's and ulcerative colitis. Crohn's and ulcerative colitis. When you see somebody with long-term abdominal pain leading to weight loss, change in their bowel habits, younger person, think in terms of maybe Crohn's disease, ulcerative colitis. If for people that have irritable bowel syndrome, which is really more just like cramping and maybe some disruption in their normal bowel habits, that's different than Crohn's and ulcerative colitis. These are true inflammatory disorders. Crohn's can really, we'll get to that. Crohn's can be anywhere in the GI tract, from the mouth to the anus. Common in the terminal ileum. A lot of times we'll see this when we're seeing somebody who presents with right lower quadrant pain, and they think they have an appendicitis, and then you take the history and they say, well, this has been going on for weeks or months or whatever. Probably likely not an appendicitis if it's been going on that long, although strange things do happen. These are patients that you're going to get some diagnostic studies on. And if you see inflammation in the terminal ileum, you see a relatively normal appendix, terminal ileum inflammation, you got to think in terms of Crohn's disease. I don't know why it showed up like this. That's probably me. But in patients, so this seems like maybe it's a Crohn's disease affecting terminal ileum. What is the more common thing that will happen? Remember, Crohn's disease is somewhat of an autoimmune disorder, so they can certainly have arthritis. They can have bloody diarrhea. Think a little more in terms of ulcerative colitis giving you bloody diarrhea. Certainly they're at risk for malignancy, probably a greater risk for malignancy than someone who does not have inflammatory bowel disorder. Perianal disease and toxic megacolon. Toxic megacolon is essentially a big, dilated, floppy colon, hypomotility, usually due to neurologic disruption in there. You see this in people that are in the ICU or bedridden for a long time, elderly people who are on medications, they lose their abdominal musculature, they'll sometimes get this big, dilated air in the colon. So in this particular case, perianal disease is probably the most common sequelae associated with Crohn's disease. It's an inflammatory disease. Like we said, you can get this anywhere from the mouth to the anus, most common in the ileum. It's also termed regional enteritis because you get some areas where the bowel will look healthy on endoscopy or colonoscopy, and then other areas that show lots and lots of inflammation. So regional enteritis, episodes of abdominal pain, diarrhea, fever, and weight loss. It can present as if it's maybe an appendicitis with right lower quadrant pain, but generally there's going to be a more indolent course. Common complication affecting most people is perianal disease, abscess, fissure, fistula, or rectal prolapse. Fistulas and abscesses can also occur elsewhere in the bowel, along with obstruction, perforation, peritonitis. These are patients that typically are going to come in. If they don't have the diagnosis of Crohn's disease, you're usually going to pick that up when you do a CAT scan of the abdomen pelvis with oral contrast. You should be able to determine this. Once they have a known history of Crohn's disease and they have recurrent episodes, unless they have signs or symptoms of perforation or abscess or infection, you don't want to do a CAT scan on these people every time they present. So maybe a plain film to make sure they're not obstructed. Typically, these patients will get placed on steroids, fluid resuscitation, plus minus antibiotics. Usually the gastroenterologists that take care of these patients know them fairly well, and the patients actually know their condition fairly well also. Listen to your patients, by the way. They generally know what's going on with their body. And in pediatrics, listen to the mom or dad, because they know what's going on with their kid. You go in and see a kid and, oh, well, little Johnny looks okay to me. And the mom or dad says, something's not right. This isn't him. Something's not right. You better listen to them. And it means you got to do a little bit more, because typically parents know their kids better than you do. And even if everything seems right at the first blush, you need to do a little bit more of a thorough evaluation. So listen to parents, listen to patients. A bimodal peak in Crohn's disease usually present young men in their 20s or again later in life. CAT scan can be helpful. Most of these patients are going to end up with colonoscopy for definitive diagnosis. Steroids, immunomodulators for severe disease, a lot of new stuff coming out that's very good. And supportive care with pain relief, analgesics, anti-diarrhea fluids, and a resumption of a lactose-free diet. Arthritis can occur with it. They can have a cold blood, but don't often have gross bloody diarrhea. That's again ulcerative colitis. Malignancy is not as common as perianal complications, but can occur. And toxic megacolon is rare in Crohn's disease, more common in ulcerative colitis. On endoscopy, you see this cobblestoning that you see to the right there, cobblestoning on endoscopy. Lots and lots of inflammation, areas of bowel that are not involved. And again, you can have Crohn's disease from the mouth to the anus. So sometimes this can be picked up on physical exam. You can have oral ulcerations, or the patient may just present with perianal disease. A lot of extra intestinal manifestations associated with autoimmune disease. Okay, we got time for one more case here. This is a very common presentation, Young female comes into the emergency department, right lower abdominal pain, nausea and vomiting, had it for about 5 or 6 hours. She appears to be very uncomfortable, vital signs are normal. Anybody of childbearing age, you pick the number, but 12 to 50, you should be reflexively doing a urine pregnancy test on them. I've had people that will come in, I'll say, "You sexually active?" They'll say no. The nurse sent the pregnancy test on them, comes back positive. I go in the room, I say, "I thought you said you were not sexually active." And they say, "Well, what do you mean by active?" So just get the pregnancy test. 12 to 50, everybody gets the pregnancy test, regardless of what they say. I had a nun, and I will tell you the nun story. Okay, so right lower quadrant pain, young female, not pregnant. She's got a little bit of a mild elevated white count. She's got a little bit of white cells in her urine. She doesn't have hematuria. When they do your urine and they spit it down, they look to see if there's any obvious bacteria in there. So no bacteria, no blood, but she's got a couple of white cells. That can be an infection, a little bit unusual in the absence of any bacteria in the urine. It can also just be an inflammatory response to something that's going on around the urinary tract system. And you do a pelvic ultrasound, which is unremarkable. So what's in the differential of right lower quadrant pain in a young lady? So appendicitis is up there, right? Think about appendicitis, 6 hours, that's a possibility. Pelvic inflammatory disease, PID, is a possibility. Certainly, you need to do the pregnancy test because ectopic pregnancy is a possibility. Middle schmerz, which is mid-cycle ovulatory pain, can present with unilateral pelvic discomfort. Some of those are benign conditions. You don't want to miss a pelvic inflammatory disease because that can lead to long-term scarring and infertility. Most of these patients are going to end up with, in addition to an abdominal exam, a pelvic examination to make sure that there's not signs or symptoms of pelvic inflammatory disease. What are the typical findings on physical exam for PID? Lower abdominal pain, maybe unilateral, can be bilateral. Something called cervical motion tenderness. When you're doing a bimanual pelvic examination, if you palpate the cervix and you move that, cervical motion, that's going to usually cause the patient to have lots of discomfort. So that raises your suspicion of pelvic inflammatory disease. Those patients, you're going to do appropriate cultures on. You're going to do a GC, a chlamydia culture, a general strep culture. You're also going to visualize it to make sure that there's not excoriations or other signs of infection or discharge from the cervix. And a pelvic ultrasound may be normal in somebody with PID. If somebody has advanced PID and they have a tubal ovarian abscess or they have a lot of pus in the belly, you're going to see something on the ultrasound. But a lot of times, pelvic ultrasound, relatively unremarkable in PID. So in this particular case, you think it'd be appropriate to just send home with oral antibiotics? Nah, probably not a good idea. What I say about MRIs, they're great, but you don't send somebody to MRI unless you have a really good reason. A lot of the stuff you can do with ultrasound and CAT scan. So CT scan of abdomen and pelvis with IV or oral contrast. It really depends on what your institution does. In the institution that I trained in, the radiologists were very particular, and they wanted oral and IV contrast. Some institutions may say, no, it takes too long for the oral contrast. Just go ahead and give them the IV contrast. A couple of things with oral contrast. If you have a patient that has an elevated BMI, chances are that you don't need the oral contrast because the intra-abdominal adipose is going to help outline structures. For a very thin person or a younger person, sometimes you need the oral contrast because you need to light up some of those intra-abdominal areas there. So in this case, we're thinking appendicitis. Probably we would give them oral contrast again, but it depends on your institution. In this particular case, IV contrast is sufficient. Most good radiologists can make a determination based on just IV contrast. So we said acute appendicitis it can mimic a urinary tract infection. You have a little bit of white cells in your urine. It can mimic a PID. The fact in this one, usually appendicitis, it starts periumbilical around the umbilicus, and then over a period of 6 to 8 hours migrates to the right lower quadrant. In this one, she had it for about 6 hours, right lower quadrant. There's locations of the appendix in the person that can give you different symptomatology. Something called a pelvic appendix, where the appendix hangs real low down into the pelvis. There's a retrocecal appendix that hangs off the backside of the bowel, so it doesn't give you a lot of frontal peritoneal signs, gives you more back pain. Appendicitis is common between the age of 10 and 30. Inflammation, infection of the appendix due to an obstruction. How do you get an appendicitis anyway? Why did somebody, what's the mechanism for an appendicitis? I mean, we all, unless you've had it taken out, we all got an appendix. It looks like this, it's hanging down. Why does it get infected? Why do you get an appendicitis? An obstruction. Sometimes you can twist. Sometimes you can get a little feces, what's called an appendolith. An appendolith, essentially a hardened stool in there. Some patients who have enlarged lymph nodes, mesenteric adenitis, that was swelling around the appendix. So you get mesenteric adenitis it's just a viral infection, but it causes some systemic lymphadenopathy, and just swollen lymph nodes around the base of the appendix can be enough to cause an obstruction to the appendix. So essentially, you're cutting off the blood supply, or it causes ischemia to the appendix. Typically going to present with abdominal pain, nausea, vomiting. If somebody comes in and they say, my little kid comes in, my stomach hurts, I have pain, and they're worried about this and that. You ask the kid, how do you feel? They start telling you. If they're hungry and they have an appetite, right away that makes it less likely. People with appendicitis typically don't want to eat. They're nauseous. You put food in front of them, they want to push it away. Some people will eat no matter what's going on, but if they say they're anorexic, that's fairly pathognomonic for appendicitis. It can vary. It can be located in the right lower quadrant, but based on the anatomical position, you can get different symptoms. We'll go over a couple of those right now. We mentioned the pylori and cervical motion tenderness would be more common with PID. CAT scan with IV contrast is good enough in most places. Some people, if you have a larger differential diagnosis, you may want to add oral contrast. Typically in older people, I'm going to add oral contrast because there's a lot more stuff that could be going on. You could have a malignancy in the area. Oral contrast is going to be a lot more beneficial in those. Graded compression ultrasound, essentially, if you have a really good ultrasonographer, by taking the ultrasound probe, placing it over the right lower quadrant, and pressing on it, you can sometimes actually visualize the appendix, and you can see fluid around it, you can see edema around it, you can actually see a cutoff or maybe an obstruction in there. So if you have a good ultrasonographer, you can start with appendicitis. Typically with little kids between the age of, 5 and 16, you don't want to necessarily give them a lot of radiation from a CAT scan. So we'll usually start with an ultrasound. If it's diagnostic, if the ultrasound is helpful in diagnostic, you can stop right there, get your surgeon on the phone, send them up to the operating room. If it's non-diagnostic, then sometimes we'll either observe them for worsening of symptoms, or we'll send them for a CAT scan, depending on their clinical situation. So ultrasound is something we'll probably see a lot more of that as you guys go through your training. Usually we dump some antibiotics into these patients, bloodspectin, cephalosporin, like Rosetta. Remember I told you below the diaphragm, E. coli, common. Anything that's in your intestinal tract, anything that's a bacteria that's in the colon is going to be at risk for causing the infection here. Definitive treatment isn't appendectomy, although there were studies that showed that antibiotics for 10 to 14 days in patients that are poor candidates for surgical exploration may benefit from 10 to 14 days of antibiotics. And because really what you're concerned about is a ruptured appendix or a leaking appendix, stool into the abdomen causing an infection. So some of these patients, if you don't have access to surgery right away, you may put them on antibiotics for a period of time and watch them clinically. Here in the States, we typically are going to have a surgeon and have an appendectomy done. Again, to try and differentiate between PID and acute appendicitis, usually appendicitis, it's going to start in the periumbilical, migrate to the right lower quadrant. Anorexia is common. Normal findings on pelvic exam. Although on pelvic exam, as you're feeling the right adnexa, if the appendix is hanging low, you can reproduce some of that pain. PID, usually it's going to be bilateral lower abdominal pain. Appetite is not particularly affected. Cervical motion tenderness on bimanual exam. Usually it's more of an indolent over a couple of days, and they may or may not have a vaginal discharge. Here they're talking that maybe you don't need the contrast. Again, oral contrast, helpful if you have low BMI, younger patients, and usually what we do is we'll give them the contrast and we'll wait about 2 hours for it to percolate down into the past the ileocecal valve. Sending the patient on antibiotics is probably not a good idea. MRI is sensitive, but again, not really a good option. There's something called an Alvarado scale. We use this in kids sometimes. Basically, it's a scoring system, and then depending on what of these are positive, it's going to give you a prediction score for whether appendicitis is a high likelihood or low likelihood. So the higher the number, the more probable it is an appendicitis. And you'll see most of this stuff is really just history, physical exam, and some laboratory testing. So no imaging here. So let's say you're working in a place that you don't have access to imaging, but you do have a lab where you can get a white blood cell count and a urine. You can use the Alvarado score to determine if somebody is low risk for it. If they're low risk, you may be able to stop there, observe them at home, have them come back in 12 or 24 hours for a repeat evaluation. And then just a couple of other things. These are some of the signs that you will mention when you're describing your examination. Periumbilical pain, remember we talked about that. moving to the right lower quadrant, nausea and anorexia. The psoas sign. The psoas sign, you take the person, you have them lay on their left side, and you stretch their right leg back. You extend their right leg. We'll see that in a patient who may have a retrocecal appendix. Obturator sign, you take their leg and you kind of rotate it out like that. We're going to see that with a pelvic appendix. And a Rovsing sign, this is where you push on the left side of the abdomen and you get referred pain to the right side of the abdomen. That's fairly diagnostic for appendicitis. So if I'm pushing vigorously on the left lower quadrant and that's causing pain over to the right side, that typically means peritoneal irritation, highly suggestive of appendicitis. We talked about common causes of fecal lift. You can't have non-operative management with antibiotics in certain select cases. And again, retrocecal appendix, that's the one where you're going to get the Rovsing sign. The psoas sign we talked about, psoas sign is for retrocecal appendix. That's the one where you lay them on the side, you take their leg back and extend it. The Murphy was the one that we talked about. I don't know if we talked about it with gallbladder disease. A Murphy sign is when you push on the right upper quadrant, patient takes a deep breath, and it causes them pain. That's a Murphy sign. And so all of these things will be things that you become familiar with if you're in an area where you do a lot of abdominal examinations, because it provides us a common language. If I'm calling you on the phone to tell you about a case, and I say, patient had a positive Rovsing sign, negative Murphy's, you know what I'm talking about, versus having to describe those findings. Okay, so it's 10 after 4. I don't want to keep you much later. So we did a couple of cases. Remember, take homes. The abdomen is a black box. Take a good history, including medication history, good physical examination. Most of the physical examination also include a rectal exam if you think there's any propensity for any intestinal bleeding. Diagnostic testing, typically it's going to be a CT scan for some of these cases. Think of common things that occur commonly, but also don't get tunnel vision. Always expand your differential diagnosis when you're seeing a patient with abdominal pain. Remember, prednisone and steroids and immunosuppressive agents can sometimes mask the symptoms. If you have patients with signs or symptoms of sepsis, altered mental status, low blood pressure, you need to be aggressive with those patients. Fluids, antibiotics, pressor agents if they're not responding to fluids. And there are certain cases you need to be very aggressive with. There's some that you can take your time with and do your diagnostic workup. Other ones, you need to get your consultants on the phone right away, get the surgeon down to see that patient, because sometimes the best place for them is in the operating room. And you always want to optimize the patient's condition before you send them off to CAT scan, MRI, or up to the operating room. Okay, I threw a lot at you there. Don't expect you to remember all this stuff and be experts, but take home a few little pearls of how you approach the patient with abdominal pain. All right, thank you all very much.